Welcome back, everyone. Today we're bringing you an absolute masterclass of an explainer on literally one of the most heavily scrutinized and audited areas in medical billing. We're demystifying the CPT guidelines for critical care coding, specifically codes 99291 and 99292. Look, if you're a coder, an auditor, or a provider, you already know critical care is incredibly high stakes. It represents the highest acuity of patient care, right? But man, it also carries massive compliance risks if your documentation isn't absolutely flawless. So we're going to break down these complex rules so you can project your revenue and audit-proof those claims.
Okay, let's dive into this. Here is our structured syllabus, designed to maximize your proper reimbursement and minimize those audit risks. We'll hit 1. Defining true critical care. 2. Time thresholds and minute math. 3. Bundled versus separate procedures. 4. Split, shared, and concurrent care. And finally 5. Audit pitfalls to avoid.
All right, Section 1. Defining true critical care. Remember, it's about severity, not geography.
So before we even think about looking at a clock or picking a CPT code, we have to establish the clinical stakes. What actually qualifies as critical care? Well, translating this dense CPT definition, it boils down to this. You must have a life-threatening condition requiring direct, high-complexity intervention by a provider. We're talking about a patient with an acute impairment of one or more vital organ systems. There's got to be a high probability of imminent, life-threatening deterioration. The provider isn't just passively monitoring the patient here, they are actively rolling up their sleeves and intervening to prevent further decline or death.
And here's a massive misconception we see all the time. People think that if a patient is physically sitting in an intensive care unit or an ED, their care is automatically critical care. Nope, absolutely false. Simply being in an ICU, ED, or a step-down unit does not dictate the use of these codes. It is the severe organ failure and the absolute medical necessity of the direct intervention that drives the code. You know, a patient in the ICU could be perfectly stable and receiving standard subsequent hospital care, while a crashing patient in a regular medical ward might be getting true critical care. Medical necessity is absolutely your North Star here.
Moving right along to Section 2, time thresholds and minute math. This is where every single minute literally counts. Now that we've established the clinical medical necessity, let's transition into the highly quantitative mechanics of this coding. Because honestly, this is where your documentation either saves you or completely sinks you. I want you to keep this number burned into your brain, 30. Fun fact, 29 minutes of intense, life-saving intervention bills out exactly the same as a standard ED visit. Crazy, right? You absolutely must hit that magical 30-minute mark to unlock critical care coding. Anything less is completely non-reportable as critical care. In those instances under 30 minutes, you've got to fall back on the appropriate standard E&M code, like a 99285 for an ED Level 5 or an initial hospital care code.
Now, what's really interesting here is how the official AMA guidelines lay this out. The parameters are extremely clear and they are entirely time-based. Because critical care doesn't use the standard medical decision-making table we use for, say, office visits, your time documentation has to be rock solid and precisely aligned with these official CPT brackets. Let's look at exactly how this minute math plays out.
So here's your minute-by-minute cheat sheet. Like we said, under 30 minutes is just standard EM. But once you hit that 30-minute mark, up through 74 minutes, you report the base code 99291 exactly once per day. Now, what if you want to use the add-on code 99292? Well, you don't just need one extra minute past 74, you actually have to cross at least 15 minutes into the next 30-minute block, meaning you need a minimum of 75 total minutes of critical care time to bill 99291 and 1 unit of 99292. Hit 105 minutes? Boom, you get 99291 plus 2 units of 99292. Master this table, and your critical care billing is going to be incredibly accurate.
Next up, Section 3, bundled versus separate procedures. Let's avoid that double billing trap. We really need to dissect what is actually included in that critical care time we just calculated versus what you're allowed to bill for separately. Guys, this is a massive area for revenue leakage and audit exposure through double billing. The CPT guidelines are super specific about services considered bundled into critical care. That means you cannot bill for them separately, and the time spent doing them does count toward your total critical care time. We're talking blood gas interpretations, chest x-rays, pulse oximetry, gastric intubation, vascular access, and temporary transcutaneous pacing. However, there are major interventions that are not bundled. These are your separately billable procedures, things like endotracheal intubation, code 31500, central line insertion, 36556, and CPR 92950. You can totally bill these alongside critical care, but there is a major catch.
So the crucial point is the critical subtraction rule. If your provider spends 20 minutes placing a central line and inserting an endotracheal tube, and those are separately billable, that 20 minutes absolutely must be deducted from the total critical care time. For example, if the provider was at the bedside for 60 minutes total, but 20 minutes was spent on those separate procedures, you only have 40 minutes of critical care time. You bill the procedure separately, and you bill $99.91 based on the remaining 40 minutes. If you forget to subtract that procedure time, you're literally double billing for the provider's time, and I guarantee you an auditor will instantly demand a refund.
All right, Section 4, split/shared and concurrent care. Let's talk collaborative coding.
Look, modern medicine is a team sport, especially in the ICU. So we really need to evaluate how to bill when multiple providers are simultaneously or sequentially caring for the very same crashing patient on the same day. So here's one of the most common high-stakes questions we get. Who actually bills for the team when multiple providers, like an attending physician and a nurse practitioner, manage the same critically ill patient? Getting this wrong is a huge compliance issue.
The answer comes down to the greater than 50% rule. When physicians and non-physician practitioners, NPPs, who are in the exact same group practice aggregate their cumulative time for critical care in a facility setting, the billing provider is determined by whoever provided more than 50% of the total time. It's pretty straightforward. You just add up the total time spent by both providers. Whoever holds the majority of that time, that's the person whose NPI goes on the claim.
And this brilliantly illustrates the CMS split/shared rules and documentation requirements for these visits in facility-based settings. You can't just write "seen and agreed." That doesn't fly anymore. Both the physician and the APP must clearly document their specific face-to-face and non-face-to-face time spent in direct management of the patient's critical condition. The medical record has to seamlessly support exactly how that total aggregated time was calculated and why the billing provider hit that greater than 50% threshold.
Now, we need to contrast split/shared care with concurrent care. Concurrent care happens when multiple providers of different specialties, let's say a trauma surgeon and a critical care pulmonologist, both provide critical care to the same patient on the same calendar day. The strict rule here, they can both bill critical care independently, provided their billed times do not overlap at all, zero overlap. If the surgeon is managing the patient from 1 p.m. to 2 p.m., the pulmonologist cannot count a single minute of that 1 p.m. to 2 p.m. block toward their own critical care billing. Overlapping time is just a massive compliance violation.
Finally, Section 5, audit pitfalls to avoid. Let's protect those claims.
Okay, you know the rules, you know the math, and you know the boundaries. Let's talk practically about how to protect your practice when the reviewers come knocking with their stopwatches for these high-value claims. Here are the major red flags that auditors are actively hunting for. Number 1, generic or cloned time statements, like simply writing, "I spent 40 minutes on critical care." Not going to cut it. You need specific details about what was done. Number 2, overlapping time between concurrent providers, like we literally just talked about. Number 3, forgetting the subtraction rule, missing the subtraction of separately billable procedure times from your total critical care time. And finally, number 4, unverified acute organ failure support. Look, if you bill critical care, but the chart just reads like routine monitoring of a stable patient, you're getting a denial. A lack of precise, individualized documentation is hands down the fastest route to losing your reimbursement.
So what does this all mean? Ultimately, accurate critical care coding hinges on two non-negotiable factors: undeniable medical necessity and precise documentation of your time. You absolutely have to master the minute math, and you must validate the severity of the patient's condition right there in the clinical note. So I leave you with this question to ask your own team tomorrow. Are you leaving thousands of dollars of revenue on the table because providers are forgetting to document that 75th minute? Or worse, are you risking massive audits by ignoring the subtraction rule? If you can confidently defend those two elements, your critical care claims are going to stand strong. Thank you so much for joining me for this explainer. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.